Hello and welcome. Thank you so much for joining us today for our event, Lesson Learned, Pandemic Prevention, Vaccine Practices, and Countering Disinformation. My name is Molly Lieber, and I'm the Chief of Staff here at NYU School of Global Public Health. We are thrilled to welcome today Dr. Céline Gounder and Professor Anna Harvey for a timely conversation moderated by GPH's Dr. Mike Merson. I'd like to say a few housekeeping rules before we get started. Dr. Merson will kick off this conversation, setting the stage for where we currently stand in the course of the COVID-19 pandemic. And following this conversation with Dr. Gounder and Professor Harvey, we'll have a Q&A period. Please submit any questions that come to you in the Q&A feature throughout the conversation. Now, without further ado, I'd like to introduce our speakers for this afternoon. Céline Gounder is an internationally renowned internist, infectious disease specialist, and epidemiologist, currently serving as the Senior Fellow and Editor-at-Large for the Public Health at Kaiser Family Foundation and Kaiser Health News, and a CBS News medical contributor. At NYU, Dr. Gounder is a clinical associate professor of medicine and infectious disease at the Grossman School of Medicine, and was recently appointed a visiting scholar here at the School of Global Public Health. In addition to her work as a public health thought leader, Dr. Gounder advises local and national policymakers on COVID, Mpox, and Ebola through her service on the Biden-Harris Transition COVID-19 Advisory Board. She has testified before the U.S. Congress Joint Economic Committee and has been interviewed several times by the House Select Subcommittee on the Coronavirus Crisis. Among other distinct recognitions throughout her career, Dr. Gounder was recently named one of New York City and State's Healthcare Power 100 and a New York State Woman of Distinction. Anna Harvey is the president of the Social Science Research Council, a professor of politics, data, science, and law at New York University, and the co-director of the Criminal Justice Expert Panel and the director of the Public Safety Lab, which works with social and data scientists to promote equitable criminal justice practices. Under Professor Harvey's direction, the Public Safety Lab's projects include the Jail Data Initiative and the Prosecutorial Reform Initiative, a collaborative effort with district attorneys' offices to develop more effective and equitable prosecutorial policies. Professor Harvey has authored 2 scholarly books, co-authored a casebook on judicial decision-making, and has peer-reviewed numerous articles. And last but not least, Dr. Michael Merson is the Interim Program Director and Clinical Professor of Global and Environmental Public Health here at the NYU School of Global Public Health. Prior to his appointment at NYU, he served on multiple positions at Duke University, including their Vice President and Vice Provost for Global Affairs. Dr. Merson served as Director for the World Health Organization Programs on Diarrheal Diseases and Acute Respiratory Infections, and subsequently the WHO Global Program on AIDS. After that, he joined Yale University as its first Dean of Public Health and the Anna M.R. Lauder Professor of Public Health. Dr. Merson is currently involved in policy research related to the COVID-19 pandemic and is engaged in initiatives seeking to build trust in public health. Welcome, and thank you all for joining today. And to kick off this conversation, please give a warm welcome to Dr. Merson.
Thank you, Molly and Anna and Céline. Great to have you with us. We're going to have a discussion, as Molly told us, about the pandemic initially, and then we really want to talk about where we are today and some of the challenges we have faced along the way, particularly in disinformation and trust. And we might take this to other areas in health, since the trust and disinformation issues are so important for our future. Let's start with COVID. Céline, we had you here with us last, I think, in late 1991. I think we were at the peak of Omicron, if I remember correctly. And obviously, COVID-19 has taken us through some very tough years. Some have said since the World War II, it hasn't been tougher. It changed our lives in countless ways. and it's still with us, though we are clearly at one of the lowest points with regard to deaths and cases domestically and globally. Probably this is due to the large number of persons who've been infected already and vaccinated, and also to a fall off, frankly, in testing. The interesting in this country, 8 days from now, May 11th, the public health emergency for COVID-19 will come to an end. And WHO is expected to announce the end of the global public health emergency sometime this year, pretty soon, I think. Last week, you may have read about the 34-member COVID crisis group released its investigative report, got a lot of media attention, called Lessons from the COVID War, an Investigative Report. And to summarize its findings, I quote, "The failure was in knowing what to do and how to do it, and then getting ready to do it. It was," quote, "a crisis of competence." The report underscored the fact that there is no operational capability for pandemic response here in this country, that here in this country, the responsibility rests primarily with state and local public health system, a patchwork quilt of over 2,800 underfunded, detached, autonomous, and often contradictory departments. It even proposed the creation of a national health security enterprise. In fact, this report was not was one of many that has pointed out deficiencies in many countries in the public health infrastructure, surveillance systems, and operational capabilities, in governance, in the polarization in our society, and in the disinformation spread by social media. All of these factors contributed to the poor responses we had around the world. So let me start by asking you each, and maybe Céline, you would go first. Can you share your thoughts on the current state of the pandemic, and maybe one or two lessons we have learned or not learned? And then Anna, same question to you, if you would just follow Céline and agree, disagree, or whatever you like. So Céline, please start.
Sure, and I was actually one of the many people who were interviewed for that report that came out last week, and I think that report is actually symbolic of the ongoing dysfunction in that we had an official bipartisan 9/11 report, and we were not and still have not been able to do the same in evaluating our performance during the pandemic. And so that report is not an official report. It was conducted by a group of outside experts. And I think that is symbolic, the fact that Congress has not been able to undertake that in a bipartisan fashion. In terms of what are some of the things that we should have learned that we might be doing now to better prepare for the future, I think one fundamental one is having open, honest, transparent conversations about risk levels and how do we measure what those risk levels are. Because what we do is really, it's not just about what we can do, it's what we are willing to do, how much money we want to spend, what kind of sacrifices we're willing to make in order to achieve a certain goal. And it's very difficult to have a conversation about, well, how much should we do in terms of all these mitigation measures without even having a target. So epidemiologists, other scientists, we can model and say, okay, if you have this much masking, if you have this much vaccination, we might be able to hit these targets with some range of certainty. But we can't make those value judgments on behalf of everyone else. And this is really a question of values. So what are we as a society, again, willing to save a life? What are we willing to do to save a life? And as a result of not having those conversations, we're defaulting sort of backwards into, well, we're not really willing to do much of anything. So that's the outcome we're going to have. So we're not willing to mask people who have gotten vaccinated or who have not gotten vaccinated at this stage are very unlikely to get vaccinated. We're dropping off on our testing. In terms of more collective action type of mitigation measures, improving indoor air quality, a lot of work to be done on that. Some areas are trying to do something on that. So for example, the state of Illinois is distributing HEPA air filtration units to schools across the state. We'll see what kind of impact that has, but this hasn't been done to scale. Paid sick and family medical leave. We had a brief experiment with that during the pandemic that has since lapsed. We had Medicaid, essentially a Medicaid expansion, you could say, because people had to be kept on the rolls. They could not be taken off the rolls during the pandemic. And starting April 1st, people have started to come off the Medicaid rolls. So it's estimated around 20 million people will lose Medicaid in the coming year. So we're actually losing, or people are losing insurance. We'll have more uninsured. And so without saying, these are the things we're willing to do, what combination of things will get us there, it's really difficult to have some of these conversations.
Anna?
Well, no, I mean, I agree with everything that Céline said. I think I would start my comments by pointing out one of the success stories, which is that, I think we saw the success of the fruit of years and years of investment in biomedical science, that those scientific investments really did pay off in a very profound way in being able to get us safe and effective vaccines quickly, much more quickly than we've seen before and than we even expected. I'm a social behavioral scientist, and so where we really fell down, I think, and this is kind of all the things that Céline was describing, was in understanding human decision making and behavior. So on the biomedical side, amazing, wonderful, and then we had these vaccines and they were safe and effective, and I think many decision makers just extrapolated from their own settings to everyone in thinking about how people would approach that decision of whether or not to get vaccinated. So in the first instance, I think a lot of us in decision-making roles assumed that people would have access to the same information about those vaccines that we did. We're reading clinical trials, right? And we're seeing the results of clinical trials being reported in publications that report accurate, and trustworthy information. Our colleagues we're all sharing the same information. We go to doctors regularly, and we're, and the view that the vaccines were safe and effective and necessary was being reinforced by our medical professionals with whom we had trusted relationships. That kind of setting, not everybody has the access to that kind of setting. So many people were watching news sources that were not conveying accurate information. They were getting information in Facebook groups, which is also, people are sharing things that weren't accurate. In the states where we saw the lowest vaccination rates, these are also the states, to Celine's point about Medicaid, these are also the states that have the lowest insurance coverages. And where you have low insurance coverage, you're not going to see a doctor on a regular basis. You don't have a trusted medical provider. So that entire, very privileged context of information and relationships where we, assumed everybody would just rush out to get vaccinated, that didn't hold everywhere. So in the first instance, I think we need to have more realistic and accurate mental models of how people are going to approach that decision. And we need to think about interventions that will be effective in making sure that people are being, don't have to go out of their way and spend the opportunity cost of their time to research things that aren't freely available in front of them, making sure that we're proactively bringing the right kind of information, helping people assess the credibility of conflicting sources of information, making people understand that others like them are making a decision to get vaccinated. That's information that helps people over the hurdles. So there's lots of very proactive interventions on the decision-making and behavior side that we hadn't made. And, I hope, although I'm probably going to be proven, the hope will probably be unfulfilled, that we would approach that side of the equation with rigor and with investment, before the next pandemic comes.
So let me build on that. The COVID crisis report, I won't quote exactly, but it certainly intimates that we as a country seem to be falling back into the old cycle of panic and neglect. or even drifted into a belief that COVID was some sort of, quote, unavoidable natural catastrophe. It just happened, and not going to happen again. But as you both have intimated, there will be a next time, and it may come sooner than later. You hear about the birds dropping from the heavens with avian flu, and you know, we know the coronavirus can mutate, and there are other viruses out there. There's a fear we are not really better off, despite what we should have learned about what you both have talked about, the value of human life, the need to respect how people make decisions. Ken Bernard, who was a colleague of mine, who was on the National NSC, the National Security Council, for 10 years under Presidents Clinton and Bush. I read a quote that he wrote very briefly, and he said, "No one wants to think about pandemics between when they occur." And so my question is, are we going to be better prepared? I mean, we have reports, and we have both of you both nicely pointing out what needs to happen. And I'm just wondering, how do we move this needle? You're both leaders in your field, and how are we going to be, and how do we get better prepared? Is there hope for this? I'm sure in your lives, like in mine, most people just want to forget that it ever happened. And yes, we wanted to prevent death, but people really want us to prevent their needing to change their lives. That's what came out a lot during this pandemic. So I just want you to tell me what you think of the future. Are we ready? And if not, what do we do? How do we get there? I think this is the really tough question for those of us in public health right now. Anna, why don't you go first on this one?
Yeah, I'm happy to. Well, so one thing that gives me hope is starting to see a shift in Washington in terms of thinking about how do we use the resources at our disposal to try to solve problems. And I'm mostly talking about the way that we allocate federal research funding. So the NIH has a budget of close to $50 billion a year. National Science Foundation has a much smaller budget, but it has a budget. But the way that we fund research through the NIH and the NSF is it's very researcher driven. So a researcher has an idea of something they want to pursue, and they submit a proposal, and it gets reviewed by other researchers. And I'm a researcher. I love the research community. But the way we do not currently allocate federal research funding is to say, here's a big, important societal problem. We need solutions. We need solutions to this problem. Contact us and submit a call to this proposal if you have a solution, and we'll mobilize everything that we have focused on that. We don't do that. What we have recently done is we've established an agency in NIH called ARPA-H, which is modeled on the Defense Advanced Research Projects Agency, where ARPA-H is supposed to take a much more problem-focused approach to research. And I'm hoping, we've been talking to ARPA-H, I'm hoping that one of the problems that they want to solve is this question of health behavior. So uptake of proven effective medical technologies. How do we solve it? And I'm hoping they'll fund that work. Because otherwise, I think we're just going to keep sort of blundering along, making the same mistakes that we keep making.
Céline, where are you on this?
Yeah, so I agree. And also touching on something Anna said earlier, I think we as a nation, we're very good at research and development. We're very bad. We're terrible at implementation and providing equitable access. And so that's why we have some of this most sophisticated biotechnology, healthcare in the world. And yet our healthcare outcomes are at the bottom of comparable developed countries. So, I think that's an area where we really need to be thinking about implementation. And that relates to this more also problem-based approach of what kind of research should we be doing that would inform that implementation. You mentioned, people wanting to go back to their normal lives. I hate to break it to everybody on the call, but we're going to see more and more of this. We're already seeing acceleration of the emergence of infectious diseases with climate change over the last century. this is just a gestalt, but if I had to say, I would bet we have another epidemic or pandemic, not necessarily equivalent to COVID, but that would be making the news, where we would have to be making some changes in our lifestyle, practicing mitigation measures. I would predict something like that will happen within the next decade, just based on the rate at which we're seeing infectious disease emerge. And I think between climate change and emerging infectious diseases and other global trends, life is not going to be the way it was. We are going to have to adapt. And if we don't adapt, that does not bode well for all of us. Now, what are some of the very specific things we could be doing coming out of the pandemic? One is modernizing our public health data infrastructure. We heard all of those stories about public health workers having to tally numbers in Excel spreadsheets and faxing those to local health departments or the CDC. The public health has not undergone the same kind of technological investment that most other sectors of the economy, including many other government agencies, have. And so that's an important area. The CDC has signed a $500 million contract with Palantir to upgrade their public health data infrastructure, but having the fanciest data infrastructure will not help you if you continue to have some of the limitations we have in data sharing. So public health powers largely sit at the state and local level, and CDC has to sign a separate data agreement with every single state, territory, tribal government, and so on, to get their data for each disease separately. So, I mean, you're talking about essentially thousands of data sharing agreements, and that's not an efficient way to be doing things, particularly in the middle of a pandemic. And so until we reform how public health is structured in this country, that will continue to be a challenge. You also have issues of workforce. So there was a paper recently published in Health Affairs documenting that since 2017, so these are trends that preceded the pandemic, since 2017, we have lost about half of our public health workforce across the country. And if you drill down by age, a more significant proportion of those losses was among people ages 35 and younger, which means that you have an aging public health workforce. And many of those people will be coming up for retirement and so on. So that really leaves us in a weak place in terms of public health workforce moving forward. Community health workers were scaled up as a part of the public health workforce during the pandemic. There are some local jurisdictions that have decided to continue investing in that kind of boots on the ground workforce. But in many parts of the country, those community health worker programs have been dismantled and defunded. So there were some sparks of hope during the pandemic, but I'm afraid that some of these things have not been continued, invested in, and some of the barriers still have not been addressed.
Okay,
Actually,
well,
and Mike, can I
yeah,
jump
please,
on?
Anna, go ahead. Yep.
Well, just one thing, Celine's point about data infrastructure, that data infrastructure is super important, not just for understanding the landscape and where vaccinations are happening, where they're not, where we need to direct effort, but also to be able to use that infrastructure to reach out and contact people directly. So at the Social Science Research Council, one of the things we're doing is we're sponsoring some research where researchers are partnering with state agencies, federal agencies, and private firms around the world to try to understand which interventions reach people and get them to become vaccinated, whether it's COVID or whether it's childhood immunizations or HPV or polio or whatever. And when you work with a CVS or a Walmart pharmacy, they have very good data records, and they use those data records to constantly, text you and reach out to you, which if you've ever had a prescription filled at, a CVS. And we're experimenting with different ways of using those messaging capabilities to provide information in different ways, to provide access to, for instance, free rides to your local pharmacy in order to get vaccinated. But you can't, the public health agencies that don't have those up-to-date, contact databases for all of the individuals, the residents in their states, are really at a loss in terms of just being able to reach out. We're working with public health agencies in Africa, where the public health agencies are contacting individual residents through WhatsApp and in WhatsApp chat groups with doctors, that is already far more sophisticated than what we have in the United States. So it's just to second, Celine's point that this is really something we need to invest in.
Céline, how did it get this way? I mean, was CDC not aware? Why weren't we better prepared for this? Do you have any idea about that?
Well, first of all, CDC was, when first established, was really set up as a research and technical advisory agency, not a boots on the ground agency. And it has not been given the mandate or resources or power to be that on the ground agency. So if you want to point a finger, I'd be pointing the finger at Congress. In order to have, Congress really needs to be the one to step up and say, we're going to empower the CDC, we're going to give them the resources, and so on. So that would be the first thing. Why are state and local health departments not better prepared may be the better question in some ways, because that's where the true public health powers reside. That's where most of the boots on the ground workforce is. And again, that's really a question of underfunding. This is not a priority. If you look at the amount that we invest in healthcare, our healthcare spending in the US is about 4.1 trillion with a T dollars per year. About 1% of that is for public health. And so when you look at the magnitude, the indifference of what we invest, that's a some people say a budget is an expression of your values. That is clearly an expression of our values. And I think that's where things need to change. There needs to be a change in terms of, is public health valuable and why? And if so, investing in it.
Okay, well, big challenges ahead for sure. Let me turn us now to this whole issue of disinformation and trust, which I know both of you have thought about and are interested in. Let me just say, to introduce this, obviously, there has been an undermining of trust in many institutions. We shouldn't start with COVID here. And this was something that already existed: identity politics, populism, anti-elitism. In fact, from the data I've seen, there has been, relatively so, a fair amount of confidence up until COVID in medical scientists. But during COVID, unfortunately, there was much more distrust in public health and in the messages coming from public health authorities and scientists. One interesting study you may have seen from the National Academy, the Council on Foreign Relations, that was published in Lancet, showed that the countries where there was the highest trust in government and in people around each other had the lowest infection rates and the highest vaccine coverage. So trust is really important and valuable in getting people to accept the right information. And I'm just wondering, I know you've thought about this. What is your thinking about how much the lack of trust and disinformation played a role in our response to COVID? How much do you attribute it to that versus the other factors you've already talked about? Anna, you want to go first on that?
Sure. Well, so I think trust is such an interesting thing, right? You can't touch it, or it's hard to measure even. Oftentimes we just measure it by behavior. The best work that I know of on understanding trust, it actually comes out of very early economic context. So when did people start, for instance, thinking that it would be okay to enter into contracts where the payment of the contract would have to happen over distance and over time? So exchanging my harvest of wheat at this point in time, waiting for your harvest to come in, and then getting it like that. Those relationships, what we know about them, they developed in contexts where people saw each other repeatedly, and they interacted in the same kind of setting repeatedly over time, and they could see when somebody will fulfill their end of a contract. And what we know, so basically what we know about trust, where it develops endogenously, kind of on its own inside settings, is where people have these repeated interactions that are stable and they see the results of trusting the person over time. In the medical context, the people where trust moved during the pandemic was not in people like I described at the beginning, people who have regular healthcare visits, they have family physicians, they're embedded in a network of medical professionals and information supporting the medical professional information. All of that remains stable. Where we saw movement was in people who were already very marginal in the health system. So people who are not seeing doctors regularly, are not receiving that kind of regular reinforcement of the doctor told me to do this and I did, and I got better. So we're starting to try to think about, okay, so what are the relationships that we can leverage to try to rebuild trust in the public health system? We're trying to think about roles like pharmacists. Right. So you might not have a doctor that you see regularly, but you might go to your local drugstore and there's pharmacists in the drugstore and you can ask your pharmacist questions. And so we're trying to start to understand how can we use the actors that people interact with regularly in their local neighborhood settings to start to, I mean, we could rebuild our public health system from scratch and have, employ a ton of people or we could start to think about how can we leverage the people we already have. So we're starting to do this. So I guess that's the long answer. The short answer to your question, Mike, is I think trust was important, but trust for me as a social scientist arises out of an institutional context in which people have relationships and see that those relationships work for them. Trust doesn't arise in a vacuum. And so we have to think about if we're going to rebuild trust in public health, in medical science, we need to think about how to leverage the relationships that people have or to get them more connected into those kinds of relationships.
Céline, your thoughts?
I do think it's important to note that scientists, researchers, doctors, and other healthcare providers are still among the most trusted in the US. But I think that also speaks to how many institutions are not trusted. And if you look at Pew polling, Pew Charitable Trust polling, you see declines in trust in institutions, declines in interpersonal trust, really over the last couple decades. So this was not a new trend during the pandemic. The pandemic exacerbated something that was already pre-existing. And I think people too often think about trust in healthcare or trust in public health as siloed from all the other kinds of trust that has been eroding over the last couple decades. I really think about trust in government, trust in media as, or the loss of trust in those institutions preceding what we've seen in terms of loss of trust in public health and healthcare. And so where you see the big decline happen is after the Eisenhower years. So Eisenhower, you have this peak in trust, and then over Johnson and Nixon, you have a big drop in public trust in government, in the media. And so what's happening during the Johnson and Nixon years? Well, you have the Great Society programs. So you have Medicare, Medicaid that are getting started. And there was a lot of pushback on that at that time. You also have the civil rights movement during that time. And I think that race and race relations, racism is a very big piece of the trust problem in this country. And I think it will continue to be. You also have Watergate and the rise, renaissance of investigative journalism, which important, but at the same time has also led to an erosion in trust in institutions. And then you fast forward a little bit more and you have the rollback of the FCC fairness doctrine and deregulation of cable, which leads to the rise of hyperpolarized media. And so then we find ourselves, people like me, people like Anna, trying to get out good information about COVID during the pandemic in this environment, in this media information infrastructure that is hyperpolarized and that rewards pretty extreme fringe views being expressed. And so it is part of this larger problem that we need to be addressing.
And social media, Céline, how about, can we do anything about that?
Well, I think the question is, can we regulate? And I think a big part of that is, are social media platforms publishers? And at least thus far, we have determined them not to be. This goes back to the early days of the internet. And I think that needs to be reevaluated. And there are other approaches to really improving what's happening on social media. But again, these problems did not start with social media. Just as COVID exacerbated these trends, social media exacerbated these trends. It was not started by social media.
Okay. All right, let me broaden this a little bit. Anna, you mentioned earlier about your research. I was reading that WHO and UNICEF had just announced that 33 million children in Africa need to be immunized by 2025 just to bring immunization levels back to where they were before COVID. I mean, that's a substantial challenge. And I know that your council is involved in some of this. Why don't you tell us a little more? It seems to me COVID set back a lot of programs internationally, well, domestically and internationally, but the vaccination of young children is really a serious one. And even many millions of children that didn't get any vaccines at all. So I think, I know the work you're doing is related to that. Can you say a little bit about how it'll help deal with this?
Yeah, absolutely. So we started funding research on I think of it as vaccination demand or the uptake of vaccination, right? So the behavior and the decision making that happens after we make the vaccines. We started doing this work I think we started in November 2021, and we were really focused on COVID vaccination. As that issue starts to lose public attention, we are shifting to supporting more work on childhood immunizations. So we just closed a call on Monday with funding from the Bill and Melinda Gates Foundation to study uptake of childhood vaccination in low-income countries in Africa, Asia, and Latin America. And what we're really trying to do is we're trying to find solutions that will work for local governments at relatively low cost, and things that are scalable, that aren't going to require things that would not be feasible for not just governments in low-income countries, but to Céline's point, state and local governments in the United States. So we're trying to find solutions that leverage technology or social networks, or technology plus social networks, things that will be able to reach a lot of people scalably at low cost. Just to give you an example, there's a research team that's been working in Sierra Leone on childhood immunization that's using colored bracelets. Just the rubber bracelets that we wear to support different causes. You bring your baby in to get her first set of shots. They have to come back like 5 times. And you get a bright orange bracelet. You and your baby get the bracelet, and then you're out in the community and people can see that you got your first round, and you come back in for your second round and you get the yellow bracelet, and you keep progressing up the scale of color. And now everybody in the community can see where you are, and importantly, you can see where everybody else is in the childhood immunization ladder. And so, and the researchers who are doing this are implementing this in a randomized controlled trial so we can see what happens. And it turns out it's hugely effective, and extremely low cost, right? It's essentially the cost of the bracelet. And it's using those social relationships and the wanting to be, a good member of a community. So that's the kind of thing. And we're using something like that with WhatsApp groups. So you go and you get your vaccination, and you get, and they message you sticker that basically you can send through your WhatsApp network, and everybody knows you just got vaccinated. So we're just like the bracelets, but it's on technology. We're working with radio stations. So DJs are a beloved form of communication and interaction in many countries in Africa. And so we're working with the DJs on a curriculum to talk about vaccines and vaccination. And we know where the catchment areas are for, how far the radio station can broadcast. And the researchers are randomizing. So again, we'll be able to measure effects kind of within and just without the catchment zone. So people are trying. We're so impressed by the creativity of the kinds of strategies that researchers are coming up with to try to reach people, to leverage those social relationships, to leverage those like the peer pressure. Think of it. And so we're hoping, everything's in the field right now. We're hoping that, this is research, right? We're hoping that in a year or two, we'll have some findings that we can report out with hopefully some solutions that governments around the world, including in the United States, can use to bring those vaccination rates up.
Is misinformation and distrust part of the problem? I mean, not just that people didn't want to go to the health facility, but were they distrusting vaccines in general, not just COVID vaccine?
So that's a really hard question to answer, right? So I can tell you that there are lots of studies that show that when you provide people with information, it shifts their behavior, accurate information, including information about, for instance, people commonly underestimate the number of people like them who have gotten vaccinated for any given vaccine. And so giving them accurate information about, no, actually, it's 50% of the community, not 20% of the community, or whatever it is, you can shift people's. So we know that giving people good information changes their behavior. What's much, much harder to ask is, does giving people bad information, change their behavior in a negative direction? And the reason that's hard to know is because we have a lot of ethical constraints, justifiable ethical constraints in the context of a research, a randomized controlled trial of giving people misinformation and watching what happens. So most of what we know about information it's associational. So we see that, somebody didn't get vaccinated and we see that they are posting, inaccurate information on their Facebook page, but we don't know what's causing what. So we're trying to focus our attention on what are solutions that will work in the context that we have, which is one in which you have information coming from lots of sources. It's not all credible, right? We want to try to signal boost the accurate information. We want to try to get accurate information to people. We want to try to leverage those social networks. And hope that if there is a negative effect of misinformation on vaccination, that we're able to counteract it.
Okay. Céline, let me broaden this even further. We have other areas where trust is key, and I know you've thought about these. I've just mentioned three that crossed my mind. How important is it really to reduce our carbon footprint, to control climate change or combat climate change? Are there any measures that are worth doing to limit gun violence? What about the ongoing debate on the safety of mifepristone, which is the latest crisis, certainly affecting thousands of women in this country? These are all related to trust, and how are we going to take these on as well? This is to me, I think COVID is just the beginning of and vaccinations, but I think it's a broader problem that we in public health really need to take seriously.
Yeah, I think the common thread here is questioning, is it a problem? So with COVID, COVID was just the flu, right? People said, climate change, is it real? Is it a problem? Gun violence, is it a problem? Abortion is a slightly different one in that respect, but effectiveness of interventions. So with respect to COVID, questioning whether masks work, questioning whether vaccines work, and so on. Similarly, with gun violence, questioning whether some of the regulations on guns will actually reduce gun violence. And then finally on safety, questioning safety. So are the vaccines safe was a big one. People saying that wearing masks actually harmed kids. People saying, with respect to guns, well, if, you know, I need to be able to defend myself, you're going to harm me by requiring me to lock up my gun separate from my ammunition because I won't be able to respond as quickly if I have a intruder in the home. People questioning the safety of mifepristone. So is it a problem? The effectiveness of interventions, the safety of interventions. Those are the common areas where people are incentivized for whatever reason. Maybe it's a company because it's going to cost them money to address climate change. Maybe it's a gun owner or the NRA who don't want to see their Second Amendment rights infringed upon. Maybe it's an anti-abortionist who is now questioning the safety of mifepristone. You know, I think that's the common thread, specifically on mifepristone. Just to give you one example also of how this plays out on the safety. The New York Times actually had a really great infographic on this, looking at the data, the body of data on the safety of mifepristone. And since the FDA authorization, we have an additional 20 years of data on the safety of mifepristone. And prior to the FDA approval, we had already a decade of data. So we have 3 decades of data essentially on mifepristone, its effectiveness, its safety. It is one of the safest medications we have, safer than commonly used medications like Tylenol. And yet what was done by the anti-abortionists in the Texas federal court case was to select a tiny proportion of the entire body of data. And then, so first of all, they're cherry picking among the studies. And then what they're defining as a serious adverse event included bleeding. I think that was actually the biggest category, where mifepristone is supposed to cause bleeding because you're supposed to cause a woman to have you're essentially inducing a miscarriage. And so anybody who's had a miscarriage would know that bleeding is part of the process. So yeah, I mean, many of these techniques are used over and over and over again, and you know, we can't anticipate they will be used in other public health crises as well.
So let me briefly ask, because I want to leave a few minutes for questions. Any thoughts on how we're going to restore trust? Do we need more community engagement, working more with health communicators, dealing more with health workers and building up their competency to increase trustworthiness? Where do you stand on how we have a lot of us are teaching students and future leaders in the field, and how do we get back to, or maybe even get farther than where we were? How do we bring us to a point where we've got to accept that social media is there, and we've got to accept that the polemics are there, and so what are your thoughts on the most likely way we're going to make progress in this area? Céline or Anna, either one. Anna, why don't you go?
Well, I guess I'm excited about the prospect to learn from some of the projects that our researchers are doing. Like here in the United States, I mentioned, we have a team working with a large national drugstore chain to find ways to get people to come in more frequently and to get vaccinated, bring their kids in to get vaccinated.
So finding trusted providers.
Yeah, trusted providers, but also doing this very using technology, leveraging technology to do this very proactive outreach, appears to work. I mean, there's a reason, that we're, that firms, our companies are always trying to message us and get our attention. That works. But the other thing that people are trying, as you mentioned, social media. We have some teams that are exploring interventions on social media platforms, on Facebook, on Twitter, where, because those platforms are open. And so the researcher, can also go on the platforms and interact with people. And, you, the researcher, can actually program accounts to be notified when somebody's reposting a post from an account that's known, for example, to post inaccurate information. And you can, send accurate information to the person who reposted, to anybody who follows that person. You can do things that engage with people who are, and so people who are deploying those kinds of interactive interventions on social media platforms. And, you know, of course, I keep saying this, but they're randomizing and they're looking at what happens. It turns out that you can actually, you know, people, you can nudge people in the direction of sharing more accurate information, of, you know, of unfollowing accounts that share inaccurate information. So I think we're just now starting to, you know, get researchers up on those platforms, start trying things that are less heavy-handed than regulation that censors or that, you know, imposes liability, but things that, you know, can be deployed by universities, by nonprofits, by public agencies. I think, you know, I think we're just the frontier of trying those kinds of solutions, and I'm excited to see where they go.
Céline, any thoughts on this?
Well, I think building trust begins with delivering credible, reliable services with empathy. If you think about who was lacking in trust and not getting vaccinated, vaccine skeptic, you might say, at least early on, that really fell into sort of two categories. You had communities of color who have historical reasons for being distrustful, and then you have right-wing partisans, which is a separate kind of problem. But for marginalized groups like Black and Brown people, why are they distrustful? Because they have not received health services in a reliable, credible, empathetic way. And so, you know, you can't market your way out of that kind of trust problem. You actually have to deliver. And so that takes time to get there. So I think, you know, that's where the conversation needs to begin.
Okay. All right, let me have a few questions. Let me start with one that came in a little earlier. What's the one regret you have about the pandemic that you would change if you could go back in time? Anything come to mind? If not, we don't have to answer it, but what would you, something that someone did or that we didn't do right, or what would you could pick one thing?
I would not have had a presidential election in the middle of the pandemic.
Okay.
I would simply not have done that.
You just would have canceled it.
I would have canceled.
No, I will say in January of 2020, I was terrified because I had already seen how Ebola played out in West Africa. They were in the middle of their presidential elections. We were in the middle of our 2014 midterm elections. The way in which Ebola was so politicized as a result of that. I mean, I knew this was going to happen with COVID. And in fact, you know, the particular president in office at that time was even more polarizing than most. But I think it's natural in some ways for the incumbent to say, I've got it under control, nothing to see here, which is actually what you're seeing with the current administration now. And then for the challenger to say, oh, this is a big problem, here's what I'm going to do about it. So I think those patterns are predictable. And then to what degree that plays out, I think varies a little bit on the setting.
What would you have done? If you were in charge.
Yeah, I mean, in Guinea, for example, they delayed their presidential elections, which actually fueled more distrust. You know, so I don't know there's a perfect solution to that. I do think this is where politicians are best staying out of public health communication and messaging, and you should really turn it over to the career scientists, public health workers, doctors, and other healthcare workers who are not part of that political process. What else would I have done differently? Not me individually, but I wish we're done differently. We had pretty good evidence by March, April of 2020 that COVID was airborne. And I started behaving as such in late February, March. And I think there was a lot of reluctance to acknowledge that. Part of it, a big part of it, is resources. Because if you acknowledge that COVID is airborne, that then means, oh, now we have to require everybody in a healthcare setting wears an N95 mask. And that costs money. And to have people use them correctly, also, technically, you're supposed to do fitting every time somebody changes brands to make sure that the N95 is fitting them correctly. And that costs money. So I think a lot of that was really about resources and not wanting to upset healthcare systems and others with what those implications would be.
Okay,
I also remember on that point, Celine, I remember, the concern that if you started going public with the airborne transmission, that there would be such a run on the limited supply of masks that the healthcare systems wouldn't, that there was there was a supply problem. We didn't, we didn't have enough supply to be able to. So I think so I don't know how much, I think it was a really difficult position for our public health leaders to be in at the time in terms of thinking about how do we manage this. I'm not saying they made the right decisions, but I think that was a difficult place.
okay, let me ask, we have quite a few, but we'll go quickly here. How can students at NYU, what can they do to help prevent spread of misinformation? How can schools do more? Academic institutions do more? Where do we play a role in countering this? You both work at NYU, but you can think of any university. What comes to mind? What can students do? What can universities do?
Yeah, I'll jump on this one because I think that's a really interesting question. One of our project teams is at the University of Michigan, and one of the things they want to do is they want to the intervention that they want to deploy. They were going to do it on Twitter. I don't know if they're still going to be able to do it on Twitter. They might have to move to Facebook, given things that are happening on Twitter. But they want to deploy a University of Michigan account with the big block M. To intervene when health misinformation appears, to intervene with corrective information. And what they're hoping they can do is leverage, the love that everybody has for Michigan football to have this be a more trusted source of information than maybe if it was like just a scientist out there. So, and actually you think about all the universities that have these extremely loyal, devoted followings, including in areas that are very under-vaccinated in the United States. I mean, all those football teams in the southern states. I mean, those are universities, and so universities could be more active, I think, in leveraging their alumni networks as a way for them to communicate accurate information among people who may not have access to accurate information.
Okay, let me move on. There's a question here about reorganizing HHS, maybe for Céline. Do we really need to be a little brave, much braver, and realize that our health and human services is just too big? The report that came out from the COVID crisis talked about a new entity that would really be responsible for dealing with pandemic response. I'm just wondering if you have any thoughts on that. Maybe too big a question, but an interesting one, whether we really need to take a hard look at the way we're organized at a national level.
Yeah, I would not say HHS is too big. If anything, CDC is too small and public health workforce is too small. I do think there is something to be said for restructuring and providing, again, CDC with more power and funding and boots on the ground capacity. And then also, part of the reason you had the COVID working group that you had an Ebola czar at the time is because of issues of collaboration across different parts of the agency, across agencies as well. And so I do think there needs to be a better structure for facilitating that and coordination across components of the agency and other agencies. But I would not say HHS is too big.
Okay, but restructuring maybe makes sense. Okay. All right. Well, our time is up. I don't want to keep you. I appreciate all your being with us and your insights. These challenges are going to continue. That's for sure. We hope people like you will continue to guide us. I hope a decade is, Céline, is it's not less than a decade. I'm worried it's going to come sooner. And I worry that we just need to, all of us, a lot of people reliving the pandemic now and selectively remembering certain things and not others. And I do think we all have a responsibility now to try to be objective and trying to figure out how to do better the next time. So thank you very much for being with us, and I'm sure we'll have you both back sometime soon. Thanks a lot.
Thanks, everyone.
Thanks, Mike. Thanks, Celine.